Hi, I'm Dr. Sridhar Ganapathy, a practicing pediatrician from Mumbai. Welcome once again to the Steer channel, an educational initiative by my teacher, Dr. Y.K. Amdekar. The topic for the day, assessment or clinical evaluation of a bony mass. So when we talk about a bony mass, it usually arises from the adjacent bone. And there are conditions wherein you could have an heterotopic ossification like myositis ossificans, which is lamellar bone formation on a damaged brachialis or quadricep muscle. You could have dystrophic calcification on a degenerative tissue or a metastatic calcification on soft tissue, that is calcinosis of soft tissue when you have aberration in calcium phosphorus metabolism, all giving rise to a mass with bony consistency. The causes of a bony mass could easily be divided into a few I's and CME. So the first commonest one is injury. The second would be infection. The third would be infiltration. The fourth would be inflammation. The fifth would be iatrogenic, idiopathic, I don't know. And then we have the congenital, metabolic, and endocrine. In the assessment of a bony mass, what we need to understand is we need a lot of rational thinking and common sense, and we need a complete and a good historical data. Let me give you a few examples. So, if you have a mother coming in the first year and giving you a history that this child was delivered by forceps and had a boggy swelling on the head, which has now become hard, bony, you know for sure this is either a calcified or an ossified cephalhematoma in a normal child. If you have a breech delivery, difficult breech extraction, not feeding well from one breast, with a swelling on the clavicle, you know it's very likely to be a birth injury, a fractured clavicle with a callus formation. If she points out to the external occipital protuberance, you need to tell her that it is prominent in some. But now the interesting thing is we are finding it also prominent in the older age group, probably because of bad neck posturing and the tug effect. A few things to understand before we jump into the topic. The benign ones are most common in children. The solitary ones are more common. But you can get multiple exostosis in children, and it does run in families. In an adult, axial presentation or the axial skeleton is more affected when you have meds because they prefer it's all in the bone marrow, the red marrow, and so the predilection for the axial skeleton. If you have a bone mass that grows very rapidly, very painful, with a lot of constitutional symptoms, growth aberrations, and the size being more than 5 centimeter, that is the size of a golf ball, with regional lymphadenopathy, you would start thinking in terms of an aggressive infiltrative disorder. Let's come to the historical data. How do they present? During a routine checkup, you pick up a bony mass. That's the first way. Second way is you have a bony mass which is painful. The third is a trivial injury and the bony mass which you had seen is become extremely painful, a pathological fracture. And the fourth way is a bony mass with constitutional symptoms, high fever, tenderness, pain. That's the fourth way they may present. So in the history, we look at age, very important. So in the younger age group, we usually get all the benign ones. So it could be an osteoma, an osteoid osteoma. It could be an osteochondroma, that is the exostosis. You could have an enchondroma. You could have a giant cell tumor. You could have fibrous dysplasia or a non-ossifying fibroma. All these are pretty common in the first 5 years, but you could get mets from a hidden neuroblastoma. In the middle, as you grow up, it's the Ewing's and the osteosarcoma and the Langerhans cell histiocytosis. The bad ones make their appearance. And in the elderly age group, it's mets from the prostate, from the lungs, from the thyroid, from the breast, and multiple myeloma, which are very prominent. Now, when you get into historical data, the second thing that we look at is the sex. Males, there is a predilection for osteogenic sarcoma and osteoma are much more common in males. And then if you look at geography, you do know that the giant cell tumors do come a lot from the south. Skeletal fluorosis, which we should not forget because they do cause calcinosis in the soft tissue, joint restrictions, more common from the north, and the enamel is definitely affected. Groundwater contamination, rock salt in diet, and excess, and even recreation freon. Then we have growth. And in growth, what we do see is growth aberrations because of deformity, fractures, and you could have height abnormalities. And when you have an aggressive disorder, you could have even weight affection. We look at constitutional symptoms in the form of fever. We look at pain, fever and pain, which is so very common with osteomyelitis. Fever and pain, which is unremitting and increasing in intensity, and with growth aberration, which we see with infiltrative malignant disorders. Pain becomes very important. If you have pain which is nocturnal, we were taught that tuberculosis is something that comes up with night pains when the protective muscle spasm is lost. But if you have night pains and the pain is relieved with an NSAID, you think in terms of osteoid osteoma. Dull aching pain, yes, you could get it with benign tumors. The aggressive ones are unremitting, increasing in intensity. That's how the pain is. And they could result in an antalgic gait, they could affect function, you could have deformity, you could have disability creeping in. Acute ones are usually trauma, which could be a trivial trauma, a pathological fracture like in a bone cyst, or it could be the acute osteomyelitis with fever in a patient with sickle cell anemia or in the age group below 5 because the epiphyseal-metaphyseal junction is very highly vascularized and a systemic infection can localize in this area. You need to look at comorbidities. That's what I was talking to you about. Sickle cell, we do know salmonella and osteomyelitis. We do know that if you have a malignancy to begin with, be it the thyroid, the breast, the lungs, the prostate, you could end up with mets. We do know that you have a malignancy and you are treated with anti malignancy drugs, chemotherapy, radiation, steroids, osteoporosis, osteomalacia, and you could get fractures, deformities, bone masses. So you need to know the comorbid profile along with the drug therapy that is on. Anticoagulants can predispose to even subperiosteal hemorrhages. So history becomes very important. Take the family history also. So there are many things that run in families like multiple exostosis, the hereditary one. You could have genetic disorders which predisposition to malignancies, bone cancers like the Leaf Romani. So a complete historical data is important. Then comes clinical examination. In clinical examination, we take the temperature, fever, with acute osteomyelitis, fever with aggressive infiltrative disorders. We look at the growth chart, height aberrations, weight aberrations. We look at the skin, cafe au lait spots, and fibrous dysplasia, multiple hemangiomas, skeletal myxomas, and various syndromes with enchondromas, like the Maffucci and the Mezabar syndromes. So, skin becomes very important, even melanomas, which can metastasize and you can have lymphadenopathies. Then we look at the jaw, micrognathia, we look at the teeth, enamel dysfunction. We look at the ear, chronic suppurative otitis media, evidence, otorrhea, otitis externa, otitis media. We do know that there is a suspicion of Langerhans cell histiocytosis. We need to look at the mandible in great detail. In these conditions, they may even have a rash. So the skin becomes very important. Then we look at the mass. Where is it? Axial, mets, marrow, solitary. Look at the overlying skin, shiny, taut, angry, inflamed, red. We look at distal sites, edema, neurovascular compromise. We look at the nails. We look at hair loss. All that can occur. So you could have a Paget's with hair loss. We look at the type of swelling, circumferential. Is it something that is jutting out of the bone, pedunculated, sessile? So inspection becomes very important. And we also look at wasting, because when there is an affection of function, you could have muscle wasting. Then comes palpation. Palpation is to confirm inspection findings and to feel the mass. And when you feel the mass, crepitus, the bone shell type of, the eggshell type of feel in a GCT, that is a giant cell tumor. The margins, whether sclerotic, hard, or not distinct. The not distinct ones are the more aggressive ones, the sclerotic ones are the more contained ones. The surface, smooth or irregular. Same way, irregular ones are the more aggressive ones. You look for the regional lymph nodes, whether there is lymphadenopathy. And you know this is something much more than an ordinary benign mass. You confirm the inspection findings of inflammation, the warmth, the tenderness. You look at the distal site, vascular patency, neurovascular compromise, edema. You take measurements. So you want to know whether it is a circumferential growth like an osteogenic sarcoma, an expansile growth like a fibrous dysplasia, a sessile pedunculated one like the exostosis, an eccentric growth like the giant cell tumor. You also want to know the location towards the epiphysis, metaphysis, diaphysis, but this is more or better delineated in a plain X-ray. And radiology comes the last, an ultrasound and plain radiology to complete the assessment of a bony mass. Thank you.